On this episode of the Ask Mike Reinold Show, we talk about how we sequence our treatments, giving away free advice to potential clients and patients down the road. And a big question we're getting a ton on is our thoughts on blood flow restriction training.
The Ask Mike Reinold Show. Helping people feel better, move better, and perform better.
Welcome back, everybody, to the latest episode of the Ask Mike Reinold Show. We're here up in Boston at Champion. Where are we? I stuttered there. At Champion PT and Performance here. We got our huge big crew in our new facility again for another cool episode. Lenny Macrina, Dave Tilley, Dan Pope, Coco Chris.
Wow.
If you haven't met our new student, Coco Chris from the University of Delaware. Welcome, Coco.
Thanks.
It's good.
Yeah.
Go
Blue Hens.
I think we're good. Len, thanks for making it on time this week.
Yep, I'm great to be here this week. Golf was good last week, but I decided to show up on time this week.
All right, Chris, what do we got? Let's get a good one this week. Get only good ones.
Okay. Denny from Nashville.
Denny.
Hi, guys. Wanted to get your opinion on sequencing of your interventions. For example, do you try to perform your manual interventions first to allow for improved capacity for therapeutic exercise afterwards? Do you like to end with manual therapy so that the patient feels good before they leave your clinic? Or does it depend on your caseload for the day and when you can fit things in? For example, if you're double booked or triple booked.
Very accurate.
I like it. Yes.
Whoa. Yeah, exactly.
Next question. No, yeah, that's actually a really good question, especially for young people just kind of starting out. How do you sequence it? And I think the second half of your question is, I hate to say it, but it is about like double, triple booked. Like it's about fitting it into your schedule. So one trick that I tell everybody, the universities might get mad at me on this one here. I do all my notes for the day at the beginning of the day. Everybody's different, right? Like Dave does it like 3 weeks later, like something like that. Sometimes forgets to do that. If he does them, right? Just, not to call you out, but okay, I called you out. But
I don't think that's ever happened.
I do all my daily notes at the beginning of my day. Okay, for really a couple of reasons, but my number one reason is I want to be prepared for the entire day. When everybody comes in the room, it's boom, I'm on, right? The worst thing you can do is be like one, not know who the heck the person is. So like, oh hey, so you got to know who's coming in, but you got to know exactly what to do from start to finish. They love that. The second you have to run over to your computer or folder, we don't have everything's EMR nowadays. You know folders anymore. The second you have to run over to your notes and kind of figure out, oh, what the heck do I do with this guy? I don't remember this guy. You've lost them. You've completely lost them, and they feel like just like a dime a dozen kind of person. So I do all my notes at the beginning of the day to plan that out. But when you do that, you can plan your day and you say like, oh, okay, I'm a little double booked here. This person, I'm going to get all this stuff in first or something like that. So yes, unfortunately that's it, but I do think there's a better way. So, instead of just me, I don't know, what do you guys do?
No, I agree. I think it is really, I would say I agree that you have to kind of go on the fly and do things, but you should have a really good general template in your mind about like how you like approaching things. So usually, establishing rapport with the person, like doing your soft tissue and your manual work first, introducing new exercises, and like maybe addressing ones they've done before and they want to go over. Like I tend to go in a like flow pattern, but then like you said, stuff just kind of comes out of the blue. If somebody shows up early, like you don't want to even sit in the corner for 20 minutes. So things happen all the time that you want to make it work. But I would say whatever works for you, try to write it out like a general template. So like I'm going to try to go by this, so that way when you go back, you'll know exactly where you were.
Yeah. So I think to go back to the question though is I think I like the way you said it at the beginning there. We do use manual therapy to get them ready for Therex quite often, right? So that's usually I would say our big component. So the way you would set up like an exercise program now is you do tissue prep, you do movement prep, then you get into your loading and stuff like that. We do the same thing with rehab. So tissue prep might be moist heat, it could be ultrasound, it could be laser, I don't know, whatever you want to do in your clinic. It could be manual therapy, soft tissue work, range motion, joint mobs, whatever it is. It's like your tissue prep, you're getting them ready. Then their movement prep, it transitions into that, and then into their loading. I would definitely say that. I don't do manual therapy at the end to make people feel good and leave good. I personally, that's not why I do manual therapy. I do it to enhance movement quality. So I want to do it before that. So anything different, Dan, Len?
I have a slight variation. I think we all do manual therapy before and end, just to tweak Mike's not that we're doing soft tissue work, but I think we usually end with a little stretch at the end. If it's a post-op, we're doing a little more range, at least I do a little more range of motion at the end. I want to check in with the person. I do motion at the beginning, exercise, and then some motion at the end to try to either improve the motion that they had when they first walked in, or just to chat with them, check in while I'm doing motion to see how it feels after they've exercised. So I think, to answer your question, I think there's a benefit to doing at beginning and end if you can. But again, to go off of your question, it depends on your schedule. I try to do it at the beginning and end, and I think we've always done that. If you can,
too.
That's a good point. We do all do that.
So I'm not necessarily doing like, I'm not digging in there doing soft tissue work, but at least to acknowledge joint range of motion, how it feels, end feel improvement, end feel changes. I think this is a definite benefit.
Agree.
Yeah. I think it depends on the patient's goal, what are they trying to get. I see a lot of patients trying to maybe improve the range of motion. So we'll try a little soft tissue work, and then we'll maybe reinforce with some exercise, and we'll go back to another manual technique, and we'll go back to some exercise and back and forth, and just whatever works best for that patient. If it's accomplishing the goal, we'll do it.
Yeah.
So.
Yeah, that's a good point. Sometimes you're playing a little bit, right?
Yeah.
Because you're treatments are the assessments too. So yeah, that was a good
Good.
point. Nice. Coco.
Jay from the UK. I'm a physio.
I like
Okay.
that. Jay from the Oak.
I'm on the bay. I just may.
Jay says, I'm a physio and often ask for advice on injuries while coaching in the gym. I happily do this, but sometimes feel I'm shooting myself in the foot when it comes to getting clients. My question is, how much is too much? Where do you draw the line between free advice and consultation?
Well, I'd say so. Us online, our online presences.
Is this Prince I?
What's the plural of presence? Presences. Anyway, we're learning so much on this podcast. Our online personalities. We make a living off giving away free information. I would never ever be afraid to give free advice to people if they ask you stuff. They're going to come to you and ask you. You've just established yourself as the expert, as the authority. They'll be back. So don't worry about shooting yourself in the foot. They'll be back. Plus, I don't know. I do that just because I think we all got into this field to help people, right? So, I want to help people when they ask questions, but I would not be afraid of free stuff.
Yeah. No, I agree. I think that along with your point, it's also like we're all very big advocates for creating a positive relationship with our clients, and being a source of information when they need it. And I think that I think that a negative experience of you not giving someone the advice and trying to being brash about it, it would stick in their mind. And then next time something comes up, they're like, oh, I might not go ask Mike or Dan or whatever. I think that because you're constantly there and you can answer their questions when something pops up, like roll their ankle, like, Dave, what do you think that, then that's my personal opinion. But I will say that sometimes you get these like very long-winded conversations, and sometimes you gotta just be like, hey, just shoot me an email and like I'll get back to it. I just gotta run right now. Like you can't always.
Yeah, if you're in the middle of something, right?
Exactly.
Yeah, sure.
So
Yeah.
Just a caveat.
Yeah, I'd say part of our model here at Champion is that we become like the consultants for people. So they're texting me stupid questions all the time. No offense, just like stupid things like, hey, should my toe look like this when I sunbathe? I don't know. That was a terrible analogy or terrible example, but like you become their resource, but they'll come to you when they need it. So
I think it's also something that's screaming at you that there's a demand in that area for PT or rehab that knows how to work with higher level athletes. It sounds like you may have a side business to consider. Yeah, and niche.
What do you say, niche or niche?
You know what? I go back and forth.
when you're around Dave, you want to say niche because you sound cooler. But us in New England want to say niche. Niche. I got a niche. But yeah, no. So one of my favorite authors, just in terms of the business world, is John Jantz, and other people like Chris Brogan. Just other people like that really talk a lot about getting people to know you, like you, and trust you before they buy from you, right? So to get to the business aspect of that, I would never be afraid of that. It's only gonna prosper in the end. Coco.
Bobby in Washington, D.C. Hey guys, what are your thoughts on blood flow restriction training in both the rehabilitation and performance worlds? I like the idea of improving strength without torquing the joint. I suppose time and research will tell, but do you think it needs the hype? Thanks.
So big question. We're getting a ton of questions about blood flow restriction training here at Champion. So Dave, we've kind of tasked Dave to.
Too.
Yeah, we've been playing with it ourselves and with some of our patients here, and I think we have a specific type of person we want to use it on. But Dave's been putting a lot of effort into
Yeah,
that.
so I've been reading a lot of the stuff, just research available, and some friends of ours online are familiar with this topic. So, and we have an open clinic, so we always toss around ideas about what is happening, what we think, and I definitely like the idea of trying to, like, that specific person post-op who can't load and is non-weight bearing maybe, or has whatever cartilage for 6 weeks they can't go heavy weight bearing, and you want to maintain that tissue quality. So I totally get the physiology of like metabolic stress and creating hypertrophy through the hormonal effect. I get that, but I think some questions that we also have are maybe we just need to learn more and expand upon is like it's still not tensile loading, right? So mechanical loading and growth factors from metabolic are two ways to promote adaptation and hypertrophy. So it's great that we have a way to maintain it maybe, but I don't feel comfortable with that being my main avenue to create adaptation hypertrophy, because in the end they're not going to be taking metabolic loading in their sport or their life. It's mechanical loading. You need to find collagen remodeling, you need to create tensile loading. So I'm sure that the people who teach this stuff would say that you have to go on to do your traditional strength and conditioning research. So I like the idea and concept. I will say that I'm not using it a ton right now, besides on myself or a couple patients, because I don't understand it fully and know exactly the protocols to go by and the contraindications and all that stuff. So I want to definitely take a course, and I think we're going to expand on it more. But there's a lot of things that have to get filled in for me from a research or someone who's done it before.
Yeah, I think the benefit, or the reason why we've even toyed with it at Champion here, is the concept of blood flow restriction training. Take a huge step back, is to say, like, what's the purpose of it? It is you can hopefully get very large strength gains with sub-maximal loading.
Right.
So by restricting the blood flow, you can still get hormonal changes and other changes that, again, Dave's more well versed on this than I am, at a sub-maximal load. So instead of having to be like 80% of a 1 rep max, you can get similar gains at a 20%.
I used 12.5% of my 1RM and I was destroyed.
Yeah, so exactly. So the goal is that sub-maximal loading, you can still get great strength gains. So when you put it that way, you're like, boom, of course, this could be a great rehab modality when somebody's non-weight bearing, especially procedures where they're non-weight bearing for so long, like microfractures or something like that, where they're so long, articular cartilage things. Man, if we could do something to do that, that would be huge. ACLs have been shown to have prolonged weakness for past a year after surgery. Maybe that's because they spend 3 months deconditioning with like the early phases of rehab. So to me, there's some good potential there. We need to kind of continue to learn, but I'm eyes wide open.
Yeah, I just think we definitely need some more longer term clinical research about comparing groups, things like that too. I think I want to find out long term, is this really going to be a big thing we should focus on?
Yeah, and Dave brings up a good point on the tensile load. Like we don't know these answers yet.
And sometimes, you need mechanical loading produces a specific adaptation from the hormonal response. If you don't have that, I'm really nervous about being, all right, let's try to sprint.
Right.
Let's try to load you with the front squat.
And I think, again, the point is that, okay, in your early phase of rehab, so your first month, this might be a good way to do it. But I think people that are just doing it in the performance realm, I don't know, does it lead to more injuries down the road?
I'm really nervous with that.
I don't know. We don't know, and it's just like everything else, right? We want to find the dose that's going to kill us, and then back it off a little bit. So
you also have to know when to not apply it, which is really important.
Yeah.
It's like you don't want to just take this like, wow, it's like every new modality, needling, something like, let's use it on everybody. Like everybody gets it.
Yeah.
People will do really bad probably with it too.
Yeah. Coco, is that it?
That's 3.
That's 3. Awesome. All right, another good episode. Thanks so much, guys. Great questions. Go to MikeReinold.com, click on that podcast link, and if you have any other questions, PT, rehab, fitness, sports performance, how long it takes Dave to finish his notes every day. If you have any questions on any of that stuff, just send them our way. Yeah, the effect of sunbathing on toes. We're here for you guys. We like a variety of questions, so ask away, and hopefully we'll continue to have some awesome podcasts. So thanks so much, guys.